Now this is the kind of injury that is very frequently missed by the emergency department staff and can often be even missed by a radiologist because it's relatively subtle. But remember when I spoke earlier about that line of the carpo-metacarpal joint? There should be a line coming across here, and you shouldn't see too much overlap between the base of the metacarpal and the other carpal bones. That's correct for the second, third and fourth metacarpals in this patient, but you see this fifth one seems to be sitting way proximally relative to the other ones, and it's overlapping, okay, with the hamate. And then when you look on the lateral projection, remember I said on the lateral projection you want to see all those metacarpals overlapping with each other. You don't want to see one jumping out the front. Obviously the first metacarpal is the exception because of our nice ability to grasp things. But this is the fifth metacarpal here, and you can see it's sitting way out the front compared to the other ones. So that is a dislocation of the fifth carpo-metacarpal joint. Often missed, obviously important to recognise, get it back in, everyone's happy. Okay, so here's an example of a knee joint effusion. So looking up here, quadriceps tendon, quadriceps fat pad, that triangular thing, looks exactly like we saw on the MRI. Fat just in front of the femur, exactly what we saw on the MRI, okay? But now you've got this soft tissue density, so similar to muscle or fluid density sitting within that suprapatellar pouch. That's a knee joint effusion. Another good example of air bronchograms. Can't trace the white vessels, but I can trace these black branching structures through here. So there's definitely opacity in the airspace. It's not as if there's fluid tracking in an oblique fissure to create this. You know, it's not pleural. It must be within the alveolar space in order to create those air bronchograms. The right heart border is completely lost. Can't see it, but I can still see the right hemidiaphragm. So therefore this is consolidation within the right middle lobe, a right middle lobe pneumonia. This patient, you can also see the horizontal fissure here being outlined by some opacity above it. The thing that sits above the horizontal fissure is the anterior segment of the right upper lobe. So you can give this patient right middle lobe pneumonia and anterior segment of right upper lobe consolidation. So here's all your consolidation in the middle lobe, beautifully seen on the lateral, and there's probably some patchy stuff just above the horizontal fissure here in the anterior portion of the right upper lobe. This is actually a game I sometimes play with my registrars because you can actually spot where the abnormality is relatively quickly if you know what to look for. Everyone ready? All right. How'd you go? You want another go? You want slower? Oh, come on. Has anyone spotted it? Anyone confident they know what it is? All right, vote. Let's go. Oh, look, you do know what it is. It's pancreatitis. Good job. The point I want to make about itis is it's the same really everywhere in the abdomen. When something gets inflamed, it gets edematous. Fluid is a little bit lower density than your normal enhancing parenchyma, so it's going to reduce the density of that organ or structure. And it's going to get enlarged because it's swollen, it's getting edematous, and the fat around it is going to get inflamed. And because fat is dark and edema is a little bit more towards fluid density, it's going to create this increased density in the fat around it, a little bit of what we call fat stranding, inflammatory stranding. Okay? So this pancreas, this is a bulky looking pancreas, okay? Slightly lower density than most pancreases that we see, particularly this area in the head here. And look at all the stranding of the fat next to it. Ill-defined margins, all this stranding. It's a retroperitoneal structure. It's in the anterior pararenal space. So you don't usually expect to get a lot of free fluid associated with it, but you do expect to get some stranding, tracking in the retroperitoneum in front of the kidney here, tracking right out into the paracolic region, okay, retroperitoneal.
So hyperacute findings, and this is hopefully what you're looking for because hopefully we're getting patients from the community into hospitals that have stroke management within minutes, ideally, under an hour, hopefully. So direct visualization of the clot will occur immediately. This is just the clot that's stopped there and you're seeing it. And early parenchymal signs. So in this case, you can see that the caudate head here is less dense than the caudate head here. And as Andrew was pointing out, when tissue gets unhappy, it becomes edematous. You add water to brain, it drops in density. We know that water resists density, right? So you stop seeing grey-white matter differentiation. Similarly, here is the putamen, gone. Here is the insular cortex with white matter subjacent to it, gone. So this patient already has parenchymal signs. And so the idea that parenchymal signs only show up after 6 or 12 or 24 hours, which you'll hear people say, is just wrong. You just need to look carefully. But once we get superiorly here, that gap between the posterior border of C1 arch and the dens is widened well above 3 millimetres. That would probably be about 6 millimetres. This is the other view that's fairly standard, which is a transoral view to look at the dens and the peg view, also known as a peg view, which is taken through an open mouth, so you can see the bottom teeth and the top teeth. And here we have C2, and there's the dens. And note how the lateral edge of this C2 vertebra intersects the lateral mass of C1, which is laterally displaced. These should align vertically. So both C1 lateral masses have been pushed sideways, and the gap between the lateral mass and dens is also widened. You would, of course, get a CT, and here we have a typical Jefferson's fracture, just as is the case in the ankle with the fibula and tibia, or the forearm. You have a complete bony ring. That's also the case with the jaw. So you really struggle to injure these locations in just one place. Usually, it's like breaking a pretzel. You'll try and it'll break it in 2 parts, or tear a ligament and break a bone. So with the C1, it's a bony ring. Here we've got 2 fractures. But that doesn't explain the widening of this atlanto-dens interval, because that's a different bone. What does explain it is this little fracture fragment here. So the dens is held anteriorly up against the posterior wall of the arch of the C1 by a transverse ligament, the transverse band of the cruciate ligament, which attaches to the lateral masses of C1 at this little knob here, and this little knob here that should be here. So that's ripped off and allows the dens to move posteriorly and potentially impinge upon the cord that's sitting just behind here.